Hello, I'm Will. Welcome to ResearchPod. Exercise and activity are good for your health. Hardly a controversial statement, but one whose applicability may be further reaching than you suspect. For example, weightlifting and heavy resistance exercise. Sure, it'll help with muscle tone and function. How about life after cancer? What does a bicep curl do for cancer survivorship and prognosis? And how does it do anything at all? Dr. Jessica Gorzelitz leads a team at the University of Iowa that aims to uncover muscle-strengthening epidemiology and what can be done to improve cancer patients' strength throughout the balance of their life. Dr. Gorzelitz, hello.
Hi, how's it going today?
I'm very well, thanks for your time. Could you tell us a bit about your research, your work, what's led you to the position that you hold now?
Yeah, I'm currently an assistant professor of health promotion at the University of Iowa, and my research is focused on physical activity and cancer survivorship, truly helping individuals after a cancer diagnosis to improve both the quantity and quality of their lives. I come from a background, frankly, as a chubby kid who was not very athletic but wanted to be. And when I was studying in college, I didn't know what I wanted to study. I just know that you go to college. And I hung out a lot in the weight room. And I found out that exercise science was a major, which I promptly switched to and really loved. It really made a lot of sense to me, especially in the practical applications of teaching, muscle attachments and how muscles work. But I didn't know what I wanted to do after college. So I worked as a personal trainer, which was really rewarding, but the behavior change on an N of 1 is challenging. So I thought, hey, maybe I'll go back to grad school. I'll get a degree in population health, figure out how to scale this. After my master's degree, I was kind of hooked and I loved science, and then stayed on for a PhD and allowed me to specialize in where my heart is really in cancer and exercise. And then after my PhD, I went and trained at the NCI, which is the National Cancer Institute. Got some very specialized training there, which has kind of led me there. So it's a long, circuitous route, a lot of themes of exercise, physical activity, and cancer. In terms of my career, I'm launching at a new institution. So building that momentum is really critical for me right now. And I think this work is more important than ever. I think I have lived experience as a woman, which is really important in science, especially when you look at those people who are studying weightlifting scientifically. It's predominantly XY people. So in terms of equity, it's really important that I'm one of the voices here contributing equally to those individuals. And then politically in the United States currently, I feel like there are more and more attacks on women ideologically and what we represent. I will not go quietly. So there is a theme of strength, not just physically, but then ideologically, that we are not just women, and sort of talking about how you can regain and reclaim that strength. Again, not equating any political strife to a cancer diagnosis, but the theme still persists. So I am the director of the Physical Activity and Cancer Survivorship, PACS, we call it PACS Lab, and that is my research group at the University of Iowa. She's brand new, only about a year old, but the purpose of our lab is twofold. What our lab group does is we contribute primary literature to the field by better understanding the relationship of exercise and cancer survivors with a unique focus on gynecologic populations. And then additionally, we help to implement that evidence by working with patients with cancer and delivering those exercise interventions. So our mission is indeed both scientific and pragmatic. As it stands currently, I have 2 graduate students, and I think we have 6 undergraduates, which is a promising start. We are looking for more graduate trainees, postdocs, and I'm trying to hire some professional lab managers and study coordinators. What's unique about where we are in Iowa is where I live in Iowa City. We have the only cancer center in the state. And cancer centers serve something called a catchment area. It's basically where patients come from, which means that if we're the only cancer center, our catchment area is huge. And this one institution, this one agency is meant to serve a lot of patients. Indeed, Iowa is very unique in that we are one of the rare states that cancer incidence or new cases is actually going up. I think we're only second to Kentucky, which is not what you would expect with all of our efforts in prevention and detection and screening. So Iowa has a huge public health challenge. So we really want to contribute to that mission, not only of the university, but then furthermore of the Cancer Center to help improve population level health, it's a big lift, but we're starting strong with our team to contribute to those missions. Furthermore, of all the NCI designated cancer centers, we're actually one of the smallest. So when I was leaving my postdoc, I had a couple of options of places I could go. And I liked Iowa for the people here are fantastic, but then also there are a lot of challenges here that are potentially addressable. But it's big thinking with good people. And it is amazing. You have people who are wealthy and they live near the cancer center and they can have all the resources to them. But we're also working with people who don't have internet like 3 hours away. And those two people should have access to the same care, but it is not that simple.
Activity as disease prevention, fairly well discussed. When it comes to what that means for after disease onset, can you give us some of the kind of the headline facts and figures, what you see from all of your experience and kind of maybe any national cancer database tracking there is about what mortality and comorbidity there is associated with inactivity, quality of life, and everything that goes with that?
Yes, this is one of my favorite areas. I could go off. So, the physical activity epidemiology has been around for decades. The first time we found out that, or some of the first evidence we had that physical activity was associated with improved health outcomes was the conductor study, the London bus studies, where they were able to look at rates of heart disease in the conductors versus the drivers to see the individuals who are up walking around taking the tickets versus the people who are sitting all day. And the findings were the conductors, the ones who are up and walking around, had lower rates of heart disease. And that is a very simple example of how we started. And indeed, our interest and obsession in cardiovascular disease in physical activity epidemiology. We know that aerobic exercise is associated with a ton of health outcomes, lower risk of death, lower risk of heart disease, lower risk of cancer, diabetes. Aerobic exercise is really important for disease prevention. The evidence base is not nearly as robust for muscle strengthening exercise. And I call it the designation here because it's really important to consider that both are different types of exercise, but a lot of us, when you say exercise, you imagine running or rowing or biking. But if exercise is meant to improve the physiology of the body, muscles and bones are a huge component to that. And furthermore, if you want your muscles to move, you need to get your heart and lungs to pump oxygen to them. So I bring up the chubby kid thing because I couldn't run. I still can't, but I was always really strong and I loved weightlifting. My dad got me in the gym and I felt like that was my place. And it was sort of body habitus agnostic. It didn't really matter how you looked. It's what you could perform. So when I started studying physical activity epidemiology, there's quite a bit on aerobic exercise, but in our surveys and in our instruments that measure population level health, there's not actually good or frequent measures of muscle strengthening activity. And I should say that this is in the public health guidelines from the World Health Organization. For us Americans, it's in the physical activity guidelines for Americans. We still have evidence to show that it has health benefits, but the scale of evidence is 5-to-1 for every 5 pieces of aerobic exercise. We might have one study, and yet weightlifting persists. Muscle strengthening activity is that beneficial for us. So I set that up before we start talking about health outcomes to remember that muscle strengthening activity, those that strengthen the muscles, are often overlooked, and there is a disproportionate representation of the evidence. Yet what we have also shows that in my study that we'll talk about later is one of the contributions to that, but we do know that muscle strengthening activity is also independently associated with lower risk of death, typically lower risk of cardiovascular disease. And in some studies, muscle strengthening activity is associated with lower risk of cancer. So population level health, it's really I shouldn't say easy. It's one of the hallmarks of physical activity epidemiology to look at the big outcomes, death and disease onset. Because typically those things happen once and they're very clean. Individuals don't have multiple death records. So analytically, it's very simple for us to look at, did this person say they were exercising here? And then was there a death later? Similarly, we can do that for diseases like, did this person have diabetes now? Did they get it later? Some of these quality of life outcomes, morbidity, function, some of the things I'm more interested in are far more complicated because they change often over time. Someone's quality of life is time, age, location dependent. And we can do different types of studies to examine the relationship of exercise on some of these outcomes. But we typically can't do them at the scale that we can for these large physical activity epidemiology investigations of hundreds of thousands, if not millions of individuals. So some of the work that we have in exercise oncology, we can do experimental studies of individuals coming off treatment or in the treatment period or when they're off treatment for a few years and sort of experimentally manipulate what they're doing for exercise and then look at how some of these functions change. And by functions, I mean quality of life, functionality, just activities of daily living performance scores. But the types of evidence is different and for many reasons.
Well, to think about the other people involved in this, coming at it from a patient perspective, how much energy, time, motivation, just like the sheer ability to get out of bed sometimes, how much of that does a patient have coming out of treatment and then like being given the idea of, okay, now we get you fit, now we get you well. There's a quote you put in, I think there's an email of, sure, you had cancer, but how do you live your best life post-diagnosis now?
Yeah, the answer is it depends, because things like cardiovascular disease and diabetes, they're very similar. This is discounting the individual level variation, but like diabetes is dysregulated blood sugar, heart disease is, it depends if it's atherosclerosis or hypertension, but we know the etiology there pretty well. Cancer is by definition unregulated cell growth. And where the person was diagnosed, what treatments they received, and what is their prognosis varies intensely. Just to compare, for example, pancreatic cancer and breast cancer, those individuals have very different outcomes on life and prognoses as how much time they could have left, what happened was associated with their diagnosis, their treatment. So a lot of us think of like cancer, like picture your average cancer patient, and it's just so varied due to this factor. So it is challenging to sort of categorize that. I'll tell you that I do a lot of work with endometrial cancer, which is the inner lining of the uterus that typically gets shed every month. But that is a tissue that can become malignant. And it's typically treated with hysterectomy and sometimes additional chemotherapy and in severe cases, radiotherapy. And I've done some focus group work, some qualitative interviews with these patients. And we recently completed a study where we spoke to some women who are currently on treatment, whether that's either right around that surgery period, they're in the chemo suite, or they're scheduling their radiotherapy appointments. And in these themes, so with qualitative interviews, we're speaking with them, we're using their words as the unit of analysis. And in every patient we talked to, there was some degree of expressing like, I know my body has changed, or I know I have lost strength. I just don't know how to get it back, or it's not a priority for me right now, or it's just frustrations by the complication of aging plus their treatment. So I think it really depends. I like working with this patient population because they're motivated and they're engaged. And some people will be, but it's really hard to categorize a group and say, yep, they're ready for training versus nah, leave them alone. So that's part of the difficulty with applying these interventions and implementing it, because everybody is different.
I'll have to look forward to that when it comes out. If we could look at some of your past publications then.
Mhm.
The lifespan paper looking at, well, span of life and quality. Could we go over some of the scope and methodology and the findings from that paper?
Yeah. So I did my PhD doctoral work at the University of Wisconsin-Madison. My accent's in there, the good old Wisconsin accent. And when I started my training there, I was really interested in overlooked cancers. So endometrial cancer is actually the second most prevalent disease in women. Breast cancer is number one. We have pink ribbons everywhere. We have marches. We have Susan G. Komen, but then endometrial cancer is, the overlooked second place person. So when I started learning about it in graduate school, I was fascinated. And to complete your PhD, you have to do a dissertation. I followed the 3-paper model. So we had to do 3 separate analyses, 3 separate manuscripts to basically prove competency. And 2 of my papers were focused on a behavioral intervention that we'll talk about basically strengthening survivors in an experimental context. But this paper was an epidemiologic investigation. And we were able to use previously collected data of 745 women from the cancer registry. So in the United States, typically every state has a mandate where cancer cases are enrolled in something called a registry. Now, this keeps track of histology, number of cases. It registers how many people there are, which is a great infrastructure for monitoring public health. But then furthermore, it was really helpful for this analysis. So we had 745 women who were diagnosed from the registry, so we indeed know their outcome. And then in this analysis, what the original investigators had done, they asked these women to self-report their activity levels from age 12, I think it's age 20, and then 5 years before their diagnosis. And this is something as simple as, Will, think back to when you were 12 years old. If you had to guess, or if you had to estimate how many hours per week were you spending in moderate intensity aerobic activity?
Oh, I don't want to answer that question.
I mean, and you, regardless of what the answer is, you won't be precise because memory is an imperfect tool. They had them repeat that procedure for age 20 and then 5 years prior to their diagnosis. So for some people, they were age 60, some people, they were age 40. It depends on when they were diagnosed. And then analytically, we were able to look at those associations. Okay, so based on the amount of activity they said at age 12 versus this age and those outcomes there. So it's not surprising to know that those were null findings in that paper. And it's mostly attributable to, I'm attributed to measurement error because, first of all, we don't have good device-based measurements. Like, this is 5 decades of data. That would be so inefficient and such a waste of resources. But it was one of the first papers for me to sort of like light my investigation to see like what's going on in this population. Is there potentially a signal? And keep in mind, this is all aerobic intensity physical activity. So there potentially pre-diagnosis activity is maybe not as important, but also most people don't recall what happened at age 12 without any good reliability.
A more recent investigation looking at telehealth, which I imagine has gained tremendous popularity in the last, let's say, 3 calendar years or so. Could you go over some of the scope and assessments from that publication? I think there were 7 assessments, 7 measures specifically.
Yeah, this makes me feel like a hipster when I talk about it because this was back in 2018. We were doing telehealth before it was cool, like pre-pandemic, before it was required. But this was work done at Wisconsin that I talked about, University of Wisconsin, with my mentor, Dr. Lisa Cadmus-Bertram, who was incredibly helpful and supportive in this endeavor. And she was an expert in behavior change and had done a lot of work in breast cancer and other cancer survivorship populations. She didn't have any strength interventions in her portfolio and was willing to take a chance on a blonde graduate student who was like, I really want to do strength training with them. I'm really proud of this investigation. It was a team effort. So Wisconsin has similar to Iowa, the state of Wisconsin only has one cancer center, one comprehensive one in Madison to serve the whole state. Now, Wisconsin is bigger than Iowa geographically, but the same type of heterogeneity exists in terms of urban, rural, dispersal. You could drive for 6 hours and you're still not out of Wisconsin if you're driving from Madison. So it is a big state. So when we were designing or thinking about a design, it was really focused on the reach. How can we get more patients into our trials that they don't have to drive back? Patients will drive, or the hypothesis is that patients will drive for chemo or radiation, which you could argue is life-saving treatment. Exercise is good for you, but it's not chemotherapy. It's not radiotherapy. We classify it as supportive care. We know it's important, but prices of gas is real, childcare is real. So we thought a home-based approach would help with that reach so that these individuals could exercise in the comfort and safety of their own home without having to come back to us. Furthermore, when thinking about endometrial cancer, that disease is associated with obesity, excess adiposity, and physical inactivity. The typical person with endometrial cancer has a pretty high BMI, and they're carrying excess body fat. That body, living in that experience, is not the same. The sort of weight stigma that these people experience, the shaming, the idea of going into the gym may not be the same as it is for you or me. So it is really important to consider the context. And we thought, and that's a true barrier. If a person doesn't feel comfortable in the space and they think they're going to be judged, they're not going to do the behavior. Like, it's pretty obvious. but the behavior is extremely important. So we thought, well, let's set up a paradigm where individuals can do it in their pajamas, regardless of judgment, hang out with their dog. So we devised a home-based strength training program. And this was a 10-week long training program. We chose 10 weeks because it's the midpoint of 8 to 12 weeks, which exercise physiology will show you that's how long it takes to improve strength. It was a randomized design. So individuals either got the exercise right away or they got the exercise later. We call that a waitlist control because we want to see like a comparison group. And it's, I would argue, unethical to withhold exercise from patients. So instead of getting it immediately, we just give it to them later. And again, we designed this program for strength. Now, we adopted a full body strength training program to be consistent with guidelines. And we had them, importantly, train in a strength hypertrophic range. So it's 2 to 3 sets of 8 to 12 repetitions. Now, a lot of these patients or these individuals had very limited experience with muscle strengthening activities. Some of them didn't have it in gym class. They didn't play sports. They've heard about strength and toning. And at the time, I had a lot of patients endorsing Michelle Obama arms as a motivator to like get their arms lean and toned. And which is interesting because past experiences are a huge predictor of self-efficacy, and self-efficacy moderates the relationship based on the social cognitive theory for an individual to do this behavior. So we know that these individuals don't have past experience. Hopefully teaching them this behavior in a context, in an environment that works well for them will lead to higher fidelity over time. So again, we designed this 10-week long program, twice a week strength training. We had really good adherence. I think overall, people adhered to 75% on average, but we had women in the trial who were above and beyond. They loved it. They were lifting every other day a week. And we did an assessment battery. It's called the functional fitness test by Jones and Rickley. If you're training for strength, a lot of people, and as a powerlifter, people will think, let's test their 1 rep max. What is the maximum amount of weight that they can lift in 1 repetition? That is wildly inappropriate for this sample of people who are completely naive to the lifting, lack the neuromuscular coordination, and you're not going to get a reliable estimate. So we use a battery that is geared towards older adults who are inactive. So we tested upper and lower body strength, upper and lower body flexibility. We did an assessment of agility and aerobic fitness. And of those 7, there's a hand grip strength, I guess that's your additional upper body strength. But interestingly, you train for strength, we saw improvements in strength, which is very consistent in kinesiology. That's the specificity paradigm. You train for what you train for. But interestingly, so in addition to seeing improvements in upper and lower body strength, we also saw changes in the timed 8-foot up and go, which is a field measure of agility. An individual starts in a seated position, stands up, walks around a barrier 8 foot in front of them as quickly as they can, and returns to a seated position. So we saw clinically meaningful improvements in that agility measure, which is surprising, good surprising. And it's not easily explained for sure, but I do think there is something to be said about the neuromuscular coordination that when learning a new movement pattern, it's not just your muscles that are doing this, your brain has to tell you what to do. So I think that there's a signal for future investigations that we're building on, because improvements in agility and coordination like that have huge implications for fall risk, for aging in place, you name it.
If we were to try and put a money value to that in terms of savings in healthcare, you mentioned the reduced fall risk, the less severe injuries, the lack of frailty associated with sedentary life, the overall cost burden that's reduced. Do you see this being a worthwhile intervention, not just for health reasons, but also for healthcare budget balancing?
I mean, I think so. Unfortunately, I'm not a health economist to quantify that. But I will tell you, with every oncologist I've ever worked with, they know that their patients need this. They see the degradations in strength. But just in the same way that you don't want me giving a chemo regimen, those individuals aren't suited for, they're not reimbursed for, they don't really have the time to give this type of supportive care. And yet they know their patients need it, whether it's in a clinician's care about their patients living their best life, or healthcare organizations could be saving a ton of moolah if you connected patients with the correct resources that they need.
We are leading directly now to the strength-specific study connecting muscle and mortality in a much more kind of one-to-one fashion than the past papers we've discussed so far. And there's a figure that I picked out from this I was reading through, that the value of improvement on mortality rates was somewhere in the region of up to 22%. Could you tell me how that it's hugely significant number comes to be?
So we kind of talked about the highlights of Wisconsin before. This was the highlight of my postdoctoral training period at the NCI. Again, I keep banging my drum of like, I want to study what I want to study, and we need to focus on this. Before I talked about these big epidemiologic data sets. One type is called a cohort or a prospective cohort. You take X number of patients, enroll them at baseline, and follow them up over time. And that's great because you have temporality. What did you do today? In 10 years, do you get heart disease? So these studies are really great. This investigation that we have actually started out as a randomized control trial that got converted into a prospective cohort. So investigators at the National Cancer Institute wanted to examine different cancer screening strategies for 4 major cancer types. They were looking at prostate screening, which I believe was the prostate-specific antigen test at the time. They were looking at lung cancer screening in the form of CT spiral thoracic imaging. They were looking at colorectal cancer screening, I think in the terms of colonoscopy, and then ovarian cancer screening with the CA124 biomarker, CA125 for ovarian cancer. So I just listed off prostate, lung, colorectal, ovarian. They called it the PLCO cohort, which is just, those are the letters of the first organ sites. So again, they were doing a randomized controlled trial to look at cancer screening practices, but the investigators had the foresight to be like, let's continue to follow these people up for decades. And that sort of cohort data from that original trial is what informed my investigation. It's important to bring this up because we probably have healthier, more liberal, more educated individuals in our study than the average population. That's typically what you get when you do research. You get people who trust the system, generally better well off, generally better well educated, which is a limitation. And it's a call for more equitable and diverse research studies. But nevertheless, we use that data to look at an individual's self-report of weightlifting. And then we followed them up over time to look at death rates. So it was great. We were using national data sets from like the National Death Index and Social Security Index. We know pretty reliably who's dead and who's not, which is our outcome. We were able to look at death from any cause, death attributable to cardiovascular disease, or deaths attributable to cancer. So death from any reason is called all-cause mortality. And these individuals, they self-reported their health behaviors in this study. And they were asked, do you weightlift? And it would be yes, no. And then if yes, you would report the frequency. So do you weightlift once a month, 3 times a month, once a week, once to twice a week, 3 to 6 times a week, or 6 plus? Which is, and that's the end of the story, period. Okay, analyze it. So that was the measure of weightlifting, which is truly a very crude assessment. For someone like me, I'm going to flag the powerlifter card again, but sets, reps, relative intensity, percent effort, what is your rest ratio, how long have you been training, like strength performance measures. There's so many things that you would want to know to parameterize the strength training components. However, going back to my very first comment that this is a very rare exposure, most studies don't actually ask about muscle strengthening activity. And at minimum here, we have frequency per week that we could aggregate out. So that is what we investigated. In our analyses, we wanted to look at what is the effect of weightlifting alone, which is, we call that independent. So regardless of how much cardio you do or aerobic activity, what is the influence of weightlifting? And then analytically, we also wanted to look, well, what's the marginal benefit for you aerobic people plus the weightlifting? So the largest point estimates in that study were actually for the people who did both, who were meeting the aerobic activity guidelines and who were strength training at least twice a week. I should back up. This was explicitly weightlifting, so I should be very careful with my language. It's not even strength training. It was specifically weightlifting. So again, individuals who were meeting the physical activity guidelines plus weightlifting 1 to 2 times a week had the lowest mortality risk. I think it was up to 49%, which is huge, lowering your risk of death. And keep in mind, on average, individuals were 71 years old in this study. So we're talking about older adults who you could argue have the highest risk of death. But the independent point estimates for weightlifting were indeed 22% alone. So regardless of how much you're doing for aerobic activity, there is a signal for weightlifting. Now, again, this type of study needs to be replicated and then followed up. But I'm very proud of this investigation, especially being one of the unique female first-led author publications in this space. I look forward to continuing this line of work.
We don't have a for sure answer here, but if you were to be pressed on any candidate reasons for what is the mechanistic cause here, if you to spitball some ideas, is there any reason why, any rationale, anything that you could put together to suggest how this functions on the kind of either the cellular or tissue-led level?
Yeah, so there's a couple of hypotheses, and we can speculate on this, obviously can't be tested. The first of which is improved physiology, because again, the weightlifting is a taxing behavior that requires both cardiovascular and lung benefit. So again, the indication of weightlifting here could be an indicator that this person is aerobically fit. This person is exercise. It's kind of like we call it the healthy adherer effect. So weightlifting could be standing in for a myriad of other health behaviors that are linked to improved physiology and then lower your risk of plenty of disease. The second of which is the strength. Weightlifting typically yields improvements in strength, and that is associated with body composition differences and lean tissue specifically. So there has been evidence of the role of lean tissue, so muscles on the body, also being associated with lower mortality risk. So the more muscle that a person has, the lower the risk of death. And this isn't like bodybuilder muscle. This is like lean tissue in the absence of sarcopenia. So it could be that weightlifting is an indicator for strength that a person has and lean tissue. And the third of which I think is really interesting to consider, is the sort of mechanism by which this could be acting. And weightlifting could be an indicator for social support and social networks. So I have a lifting crew, people that I like to hang out with at the gym. It's germs, I'm building my immunity, but I have this social contract with these individuals. I get to see them. People care about me. They want to see if I'm coming to the gym and I care about them. So for these older adults, this could be, if they're weightlifting, they're not alone, they're not isolated, they have a community in the form of weightlifting, assuming that they're not weightlifting alone, which is an assumption that we have to have. But given that the fact that most adults don't have elaborate home gyms, I think that's a fair assumption.
Do you see this being indicative of weightlifting for umbrella health?
Yeah, so it's interesting because this PLCO data set, again, they're probably healthier patients or healthier individuals than your average American. But these were just regular older adults. They didn't have to have any former diagnoses. So I think it speaks to the applicability of getting older adults to do this or consider adding it into their routine. And it's a consideration, right? This isn't a demand. But it is important to consider because the dose, or AKA the frequency of activity that individuals were doing in this study, was no more than what's in the physical activity guidelines or in the WHO guidelines. This isn't some super Herculean effort. It's twice a week, just training those muscles, making sure you don't lose it. So you have to use it. I will say that in future directions, maybe I'm getting ahead of myself, but we're replicating this methodology, an analytic process, to look at cancer survivors. So in these cohorts, we can identify individuals who have had an incident cancer crop up while they were being followed, and then compare their rates of post-diagnosis weightlifting on mortality risk. So that analysis is currently underway, but to my knowledge, that will be the first post-diagnosis weightlifting epidemiologic investigation in cancer survivors.
Do you find that there might be, and this could be something mediated through the telehealth investigation, the value of having a guided physical intervention rather than someone who might go off the deep end and end up, I don't know, trapping their foot under a Bowflex bar that falls out of things and having some negative health effects associated with doing either too much or the wrong thing or not quite in the right form? Are there any tempering of expectations we should have against possibly too much exercise or the wrong exercise for the wrong people?
Yeah, it's a good question. important to consider that exercise is inherently dangerous. All the adaptations that we get from exercise are from stress. So the easiest thing to do is sit on your couch and do nothing. That is your zero risk situation. The difficulty is that exercise has to be applied very specifically and safely to benefit from these adaptations. And for cardiovascular exercises like aerobic activity, it's intuitive for people. They walk as quickly as they want to. They run as long as as they can, or whatever their metric is. Muscle strengthening activities like weightlifting are so much more challenging because if an individual is inexperienced with this, it takes so much more support in the beginning period. Now, our lab we always say, like, we're teaching people to fish because we don't think that people need trainers forever. There are certainly going to be people who need personal trainers, but there are also people who you give them 10 weeks of training and they're ready to join their local gym. There are some people that they start this program and they love working out at home. They love being with their dog or what have you. There are people who spend 10 weeks in the training program and identify that they want a support buddy or peers. So it's really important about this initiation of the behavior and then the handoff. Our paradigm is that if we sort of heavily support this beginning period, teaching about the biomechanics, where are the muscles working? How do you breathe? What is the progression schema once you get stronger? That an individual builds that mastery and that self-efficacy so that they're ready to go. And when I say go, that's different for every person. So then going back to my former comment about connecting patients to resources, there are community-based programs, there are individual gyms. You could hire a personal trainer or you're perfectly fine to stay at home. It's really important that the behavior continues, but there's not one answer. It's sort of like figuring out what works best for that person. And I will say, just getting back to your former comment, that is probably the most, when we were talking about like older adults, these are, women, endometrial cancer survivors who are getting strong. It speaks, like, this sort of research paradigm speaks larger to the role of, in a way, women in society. These women are post-menopausal typically. They're older. They're not really as valuable in society as they once were, especially nowadays when women are valued for their youth and for their beauty. And they may or may not have grown up in an area where they were encouraged to do sports or exercise. And yet this population has an interest and they want to learn and they want to grow. And it is so empowering to see these people reclaim their health and reclaim their bodies. Cancer can be such a terrifying experience. Your outcomes are in the fate of your team. You're trusting your oncologist. You're hoping that the surgery goes well. You do whatever chemo they tell you to. You trust these people. And the oncologists and the clinicians, they know what they're doing. But there is an enormous loss of control when a person goes through that in their life. And I can't guarantee that it'll never happen again. But I can help these patients reconnect with their body and their strength and reclaim it. Previous investigations in endometrial cancer have focused on weight loss, because we do know that adiposity probably is carcinogenic. But there is sort of something very demoralizing about constantly making yourself smaller and lesser and losing. And it's flipping that and being like, well, you got these cards that you were dealt, but can we empower? Can we strengthen? Can we build? And so far, that's been really successful. And I think that that's something that our lab really wants to focus on.
Any plans for that, not just weightlifting analysis, but also the well-being analysis of activity, of quality of life, of occupying space and being back in your body after being kind of medically forced out of it in order to get a cancer out?
Yeah, we have a project that we're working on right now. It's a great question. The great thing about where I am geographically is I have the connections with the gynecologic oncologist at Iowa. I trained at Wisconsin, so I have my colleagues there. And then I have some phenomenal team members at the Mayo Clinic. And we're working on a large application to sort of pull all this together, because there's all this like patient-reported symptom. And patient-reported symptoms are one, and quality of life is a component of that. But then also the sort of psychological well-being and the psychological reclamation that these activities can have. The work that I've all done thus far, admittedly, is quite small, pilots of like 10, 20, 40 women. So in order to get a large sample size to do these types of investigations, we have to collaborate. And luckily, these oncologists are some of the best people you'll meet, and they're very eager to collaborate. But we need a lot of individuals to be able to glean this level of inference. So to answer your question, yes, it is a work in progress. And it's something that I think is truly unique and I think needs to be talked about more.
Well, this is a good opportunity to mention some of the other ongoing studies that you've got going and upcoming publications. Could you give us a whistle-stop tour of some of those?
Yes. So currently, I have a pilot grant from the American Cancer Society, and that's also an endometrial cancer. We have two aims associated with that grant. I kind of talked about the first one. It's our qualitative interview study, and that publication is currently underway. It's just amazing to look at the themes there of these women who are on treatment and in different stages of their life, but having very similar attitudes and different preferences. And there's a theme of body shaming and body habitus fear and like overwhelm. So that is underway. We also are currently replicating our Wisconsin trial of that home-based exercise program. We're doing it here in Iowa. So we have recruited 10 patients with endometrial cancer, and they're doing a combined now strength and aerobic program. We've given all of our participants Fitbits that we monitor remotely. And I have a trainee, a fantastic trainee, who is monitoring and serving as the study coordinator for that study. So we're using that as a proof of concept, sort of clinical indication study to see combining strength with aerobic in that order purposefully to see if the magnitude of effect is the same for this population. Because it could be that when you start to dilute and add multiple behaviors, that it could decrease the strength effects. So we're currently recruiting for that. We have our patients on trial, so stay tuned on that. We also have a more epidemiologic investigation going on, which is the instrument development project. As I've kind of alluded to throughout this interview, the way that our assessment tools are limited in terms of physical activity epidemiology, and a lot of the surveillance tools that we have or the ways that we monitor behaviors are crude. And they're crude intentionally because we want the most efficient way to measure behaviors. However, when we're thinking about access to physical activity and planning future interventions, we're missing a whole lot by just asking, well, are you active? Yes or no. So we're currently working on developing a tool that is specific to cancer survivors in Iowa, which is going to include a heavy rural component, but looking at different factors that influence behavior. So not only asking about behaviors, but interpersonal relationships. What would you want from your provider? What about reimbursement, preferences for community versus partner? And to create a brand new instrument is a lot of work. We have to do the appropriate testing called the psychometrics of the instrument to make sure that this test is, or this assessment is actually testing what we think it's testing. Are participants interpreting the questions the way in which we intend? And is this instrument not only sensitive to change, but then also is it reliable and valid? So it's very like research methods, like Epi 101 type of project, but it is very important for sort of understanding the context of what's going on in Iowa, because we often make a lot of assumptions. And so far, culturally, Wisconsin and Iowa seem very similar, but this investigation is revealing a lot of contextual factors that are indeed quite different.
Well, we are almost leading into the conclusion questions now, but are there any other papers or projects that you want to give a special shout out to? You mentioned there was the one that was coming up in publication. Anything else that's in the works that readers might be heading to soon?
So there's two I just want to briefly highlight. I've already talked about one, the sort of weightlifting, the epidemiologic investigation of post-diagnosis weightlifting and cancer survivors. Based on our analytic data thus far, we should be able to look beyond just breast and prostate, which unfortunately is a lot where the evidence is in exercise oncology, and it doesn't capture the whole landscape of cancer survivors. So that is several months out, but that will be coming. And then one of my colleagues from my postdoc, Dr. Courtney Williams, and I are co-leading an investigation using SEER Medicare data, which is a linkage of cancer registry data and health insurance claims-based data. And we're looking at cancer rehabilitation patterns in breast cancer. Again, breast cancer research is very represented. It's typically because we have large sample sizes with which to draw. But we are looking at patterns and demographic factors associated with cancer rehab. One of the reasons why rehabilitation services are really important is because physical activity and exercise exist on a continuum. If you have a bad back, for example, or if you have a frozen shoulder post-diagnosis, that is going to impact your ability to do recreational and leisure time activity because you have this concern or this functional limitation. So we're currently finalizing that data. It's brilliant because it is a national data set and it allows us to draw inferences broadly. We have about 60,000 breast cancer survivors in that analysis. Following my line of research in physical activity and cancer survivorship, we have evidence that muscle strengthening activity in the form of a strength training program is really beneficial for endometrial cancer survivors. The question remains there as to how to scale this so that more patients have access to this type of strength exercise, given that the guidelines are that all cancer survivors do this type of exercise twice a week. But then even on a population level, we were able to lead an investigation of weightlifting in older adults, which revealed that weightlifting was independently and in conjunction with aerobic activity, it was both associated with lower risks of mortality. So some evidence that older adults too should be doing weightlifting exercise. But again, these doses aren't enormous. It's more important to consider that these are consistent with the physical activity guidelines, and that when an individual is thinking about these behaviors and why people don't do it, it's quite complicated. And the context truly matters. And there are a lot of factors that impact both participation and access.
And if there are any doctors, healthcare providers out there listening to this who want to frame to their patient that this is going to be a worthwhile intervention, despite the weakness that they might be feeling, how would you encourage them and encourage other patients to take up the weights and start lifting?
It's finding the correct support resources that an individual needs. It's considering that individual context. I will say that everything we recommend is evidence-based. It's not just the result of my few studies. This is based on international expert consensus roundtables. The evidence is supporting the frequency of this behavior, but the amount of support and ability of every person will vary. So I know some really good physical therapists who specialize in cancer who help individuals begin activity to begin to address some of those symptoms and impacts. There's a lot of community-based programming across the United States. It's not as common as you would think, but to find the types of resources that you need, I think the home-based approach can be really advantageous for many reasons. But there are support groups and community gyms and other things like that. I think it's important to consider that not one person can be all things to all people, and it's connecting with the support and resources that the person needs, because it will vary.
And if anyone listening to this wants to hear more from you specifically or from anyone else at the PAX Lab and your upcoming publications, where can they go to find out more?
I have a lab website. You can Google my last name. It's Jessica Gorzelitz, U Iowa, and it'll pull up my faculty profile where my lab website is located. I'm also always open to email questions. It's my first last name at uiowa.edu. I've heard a lot from people. When my last publication came out, it was very divisive, and I'm always happy to engage on this topic. I am currently recruiting for graduate students and postdocs. If this type of messaging and this type of work resonates with you, I'm always happy to talk about degree options. Our programs offer funding for 2 years for master's students typically, and then PhDs are guaranteed for 5 years. I'm looking to build my lab and train trainees who are committed to the mission and who are interested in this type of work. So if I can use that as a plug for people to contact me for education and employment opportunities, this is my life's mission, is to help individuals with cancer to improve their quality and quantity of life. So I'm always happy to engage with whomever.